Thank you. Thank you for standing. It's hard to come in after lunch. I'll give it a try. Thank you. So my name is Mohamud Ali. I'm here on behalf of the hospital that I run, as well as RUFA, which stands for Rural and Urban Private Hospital Association of Kenya, which I'll introduce at the very end. So some of you may not have heard of Bungoma. We are a village in respect to Nairobi, but it's a bustling town close to the border of Uganda. We pack a punch because we are 1.8 million strong. That's a big town. Bungoma, I'm sure for those who understand Swahili, no ngoma means drums. So it used to be the place where elders used to come to meet, have a drink, and discuss very important matters. So the drums used to beat, and all the elders would coalesce at Bungoma town. So hence the name Bungoma. Now, our economic activity is mainly sugarcane farming or farming in general. And some would argue that, farming is the, mainstay of Kenya. So we actually run the show here, not Nairobi. Right, so who are we? We are a level 5 hospital currently, but we were established in 1992. It's a family-run business, and we offer an array of services as pertains to a level 5 hospital. But we started somewhere, and Frappe has a lot to play there. So just briefly discuss a bit about healthcare management information system and its challenges. One, hospital operations are extremely complex. There's no, one shoe size fits all kind of a solution. It's a problem that even the, developed world face every day. We also lack standards in Kenya. We've been lacking for the longest time. So that's another problem that we face. We also have, very high cost of implementing HMISs. So, we are quite resource limited. Healthcare has been underfunded for the longest time. WHO proposes 30% of GDP, I think. We are nowhere near that, not even close to half that. So we are greatly under-resourced. And that brings in costs as a factor of consideration whenever you're talking about HMISs. So our journey started when a small hospital, a 24-bed capacity hospital we were operating, encountered some headwinds, and we were contemplating selling the hospital, the business entirely. And I decided, let me go in, see if there's something that we can salvage before we sell it. So it took me 3 months to learn the business, to understand how it operates, and to identify what ailed the hospital. So I narrowed it down to a couple of things. One was, observability, lack of accountability, wastage, the things that ruin a business. So it all, came down to the choice of an HMIS, a tool that you can use to make sense of the business properly. So in my journey of discovery of, the different open source software, open source because we were trying to save some costs here and there, I encountered quite a number of open source systems out there. And the minute I landed on Frappe, I forgot everything else. I don't even remember some of those names. It felt natural. It's like that storybook or that novel. When you start the page, it's a page turner. You just go all the way to the end. So I've been hooked on Frappe ever since. No one can convince me otherwise. So we are here. We try to implement it, and the uptake, the buy-in from our staff, it was very easy, it was instant. we managed to save a lot of our costs, reduced a lot of our wastages, and brought in a lot of our accountability, and in turn, turned us into a level 5 as we speak today. So, thank you. So in a way, taking that forward, basically, that pay it forward kind of principle, we're also here today sharing our experiences. You're seeing some of the stats there. They are dwarfed to what MTRH is doing currently, but we also pack a punch in a sense relative to our size. So we grew from 5,000 customer base to now 100,000. We are having 20, now it's over 20, I think, as of today, insurance companies onboarded. As for services, we now have 104 beds. We went from 5 to 16 services and amenities. We were doing 15 surgeries in total then. Now we are doing over 100. In terms of our footfall, 40 to 300, over 300. Like I said, we are level 5 hospital. Our revenue was a sixth of what we are right now, and all is credit to Frappe and Frappe team's efforts. So, as part of our giving back to the community, we are doing a lot of charity work as well. We are, through an NGO, we are doing a lot of surgical cases to pediatric patients. We are also sponsoring, the needy in terms of buying for their healthcare premiums for a whole year. We also operate a fund that we assist those who cannot pay their hospital bills. And we are very big on blood donation as well. We do work with the county governments to run, blood drives in our counties. So we're doing more than that, of course, but this is just a few things that we're doing. So Dr. Mwogi mentioned a few things that wowed him when he came to us. It wouldn't be fair not to show you some things. I just slapped on these images while I was sitting at the back. I didn't plan to share this, but it was mentioned, so I'll share a bit. So what you're seeing on the screen here is a duty roster. Basically, running a HR in healthcare is very problematic. You basically, you'll pull your hairs out. So we decided to create a duty roster, which is tied to a biometric attendance system at the back end. And it automatically computes the work hours, the shifts, based on the duty roster. And this is all, you do it visually, basically. And you can see even the hours are computed at the very last column with the sufficiency of staffing right at the very bottom. So that's one of the things that we did. Dr. Mwogi mentioned images. We capture some images at different points where, of concern mostly is fraud. We want to combat fraud. And this has been a major saving for us. Somebody mentioned about queuing. We started implementing queuing system, but when we grew, we sort of left it to the back burner. We implemented a Swahili version of queuing system because most of our clients are illiterate. So that's something that we left off along the way. We also integrated with NHIF, so you can see all this data showing to you right now. This is straight from the NHIF. We can track, the allocation versus what has been spent, and then manage that accordingly. We can also see who the dependents are, and a lot more other information. So coming to the future, it didn't stop there for me. I joined RUFA as an executive member. And we are now currently implementing something called RufaSoft based on ERPNext. We are a 350 member plus hospital association, and it ranges from clinics all the way to level 6. We are spread in level 5, not level 6. We are spread in all the 47 counties, and we are currently piloting in 18 hospitals. We were lucky to get some credit funding from AWS, which is what we are using currently, and we're running Kubernetes in the back end. So that is us. Thank you for listening to me, and all the best. I'll welcome any questions if you have any. Thank you. I started off with version 7, and I found it very easy to adopt from then on. I think there's the back-end stuff where you need to set up a bench and all that. That's quite complicated, yes. But once the system is up, transitioning was easy for us, because what is available in the market right now cannot serve us, or wasn't serving us at that time. So I don't know if that suffices as an answer. Right. Okay. So it's an ongoing concern, definitely. It's a new challenge for us, considering that we are trying to force a monolith to all situations. It's forcing us to adapt new ideas. It's a challenge, definitely. It's an ongoing concern. It's not smooth all the way. And I say, that's the challenge that as Africa we need to sort, because it starts from the very bottom, where the resource is extremely limited. So if we can innovate from there on, I think it'll be easy up here. It goes back to the resource limitations. And with Kubernetes, the learning is that you can squeeze every compute, every RAM to the maximum, and that's the basis of why we jumped onto the Kubernetes. It's a nightmare to work with, but the savings are worthwhile. All right, thank you guys. Something.